Now we're going to move on to information bias. And information bias is a catch-all for a ton of different biases that go by a lot of different names, but it all boils down to the same thing, which is essentially mismeasurement. So our goal is here to understand that information bias boils down to mismeasurement, and especially differential mismeasurement. But before we get started, I'm going to give you a quick example of a really extreme bit of information bias that crept into a study looking at where people come from. I'm going to ask you to hold this for a second. Sure. And where are you from originally?
St. Petersburg, Florida.
Bismarck, North Dakota. Great, thank you very much.
Thank you.
Where are you from originally?
Originally, like, born and raised, Washington, D.C.
South Bend. Great, thanks. Where are you from?
Tennessee.
All right, Kentucky. Great.
Chico, California, home of Aaron Rodgers.
Nevada, got it. Where are you from originally?
I'm from Baltimore, Maryland.
Antarctica.
Antarctica.
Great, thank you.
Concord, Massachusetts.
Illinois, thank you very much.
I'm from Stamford, Connecticut.
Key Biscayne, great, thank you very much.
Thank you.
Where are you from originally?
I'm from Milwaukee, Wisconsin.
Vladivostok, great, thank you. All right, so what we saw there was an example of someone just getting it wrong, right? Asking for a data point and recording it incorrectly. That's mismeasurement. That's going to bias your results. If you just record random stuff on a piece of paper, your results are not going to be very significant, right? That will bias you towards the null. But there's a variety of other types of information bias too, and so I want to give you just some examples. An important one is called detection or ascertainment bias. This is when you follow one group or one type of person more closely than another. So they have an opportunity to have exposures seen more often than another. So this is a paper that looked at something called acute kidney injury. This is, full disclosure, one of my papers that my lab group published. And what we were interested in was that this finding that people who have acute kidney injury when they're in the hospital, which is a sudden decline in kidney function, do really badly over time in the hospital. They're more likely to die in the hospital. They're more likely to have all sorts of bad things happen to them. And the question is it the acute kidney injury that's causing all that bad stuff, or is it not? And one thing that a lot of people hadn't thought of was the impact of ascertainment bias. To define acute kidney injury, you have to measure something. In this case, it's a blood chemical called creatinine. But you have to stick a needle in someone's arm and draw blood and send it to the lab. In fact, you have to measure it a couple of times because acute kidney injury is defined by a change in the creatinine level. You might see where I'm going with this. The more often you measure creatinine, the more you're able to see the people with acute kidney injury. Taking it to an extreme, if I never measure creatinine, I can't define people as having acute kidney injury at all. And so what we found was that sicker people got more blood tests. So they had their creatinine measured more often. And so a lot of the relationship linking acute kidney injury, this concept, to bad outcomes was actually due to the fact that we diagnosed acute kidney injury more frequently just because we were doing more frequent blood tests. That is ascertainment bias. The more you measure, the more likely you are to develop acute kidney injury, but the sicker you are, the more you measure. So when you're thinking about information bias, you always want to ask yourself, what was measured wrong, the exposure or the outcome? Well, our exposure in this case was acute kidney injury. Our outcome was death and things like that. The exposure was mismeasured in an extent. We weren't capturing all the acute kidney injury because in the less sick people, we weren't checking as often. And so you only check in the sick people. That's information bias. It makes it look like acute kidney injury is linked to death when in fact it might not be. Here's another example, not one of mine, maybe more important for the college students out there, the relationship between cell phone use and academic performance in a sample of US college students. So this was 536 college students, and they mapped their self-reported cell phone use to their GPA. So when you see a study like this, you have to think, okay, could information bias be at play? Well, the exposure is cell phone use. The outcome is GPA. So the outcome, GPA, depends how they got it, but if they just looked up their academic transcript, it's probably pretty accurate, probably not mismeasured. That seems fine. But the exposure, cell phone use, that was self-reported. So is it accurate? We don't really know, and it's possible that people with low GPAs might systematically overestimate their cell phone use, whereas people with lower GPAs might underestimate their cell phone use, or so on. The better way to capture cell phone use would be to, install an app on the phone or something like that that actually really measured it. So anytime you see the word self-report, think information bias. All right, co-intervention bias, another form of information bias. So here's a study appearing in the Journal of American Medical Association, which was looking at the use of acupuncture for chronic knee pain. And this was a randomized trial, but like many randomized trials of acupuncture, they didn't just have an acupuncture versus no acupuncture arm, because they realized that putting needles into someone's skin might actually do something not magical with qi and stuff, but the patient obviously knows that it's happening. There could be significant placebo effect there. So what they did is they had usual care, needle acupuncture, the sort of standard, laser acupuncture where they use kind of laser beams, and then sham laser acupuncture where they use laser beams but not in the right place. And what you can see is the overall effect in terms of improvement in pain, and I will tell you that the difference that you see is that in terms of statistical significance, everything was better than usual care, but none of the various types of acupuncture were better than any of the other types of acupuncture, statistically speaking. So when we look at studies like this of acupuncture, oftentimes they're reported as acupuncture, even sham acupuncture, is better than nothing for pain. And that's a little disingenuous because you might as well be saying the placebo effect is better than nothing for pain, right? We're really interested if acupuncture, placing the needles in a specific place, makes a specific difference. So what is the bias here? Well, the exposure is acupuncture, and the outcome is pain. In this case, both of these might actually have some information bias, but I'm going to argue that the exposure is biased by something called co-intervention bias. When any of the people in these three groups got their treatment, it wasn't just that they had needles put in their knee or whatever. They went into a quiet room, it was dark, there was a provider there who spent some time with them, they might have had conversation. All of these things are happening in that group. That is happening along with the acupuncture, co-intervention. We don't know if it's the acupuncture or all the nice talking and hand-holding that actually makes the difference when it comes to pain. So when you are thinking about studies like this, where the patients are aware of which treatment they're getting, be aware of those co-interventions that might be going on, and realize that that's a form of information bias, because they're labeling this group the acupuncture group, not the acupuncture plus hand-holding plus soothing talking group, when that, in fact, is what's really going on. Another example here, a trial called SPRINT, a randomized trial of intensive versus standard blood pressure control. This was a study that randomized a large number of people to get their blood pressure really low, systolic blood pressure less than 120, versus a more moderate target of less than 140. They saw a significant benefit in terms of all-cause mortality. So the lower you got the blood pressure, the less people died. That was a big finding, big bit of news, important study. But look at the methods, and what you can see is this statement, quote, "Dose adjustment was based on a mean of 3 blood pressure measurements at an office visit while the patient was seated and after 5 minutes of quiet rest." Okay, so what they're talking about here is their assessment of the exposure, the blood pressure, right? That's the exposure, the outcome is death. Their assessment of the exposure, their measurement of the exposure. They measured that exposure after the patient was lying down for 5 minutes in quiet repose, had the blood pressure cuff cycled 3 times, and they took the average. Has that ever happened to you when you got your blood pressure checked? I'm going to suspect that it has not. So the measurement of blood pressure here is not quite accurate with respect to the real world. I mean, it may be more accurate than the real world in the sense that, maybe that's your true blood pressure when you're nice and relaxed. But if that's what no one does, then the target of 120 is not very meaningful. Because really it's a target of 120 after you're lying down for 5 minutes and they measure it 3 times and they take the average and you're in quiet repose, right? So there's a bit of measurement error in the exposure here, potentially introducing some bias. Let's do some quick ones just to round out our types of information bias. Confirmation bias, you look harder for an outcome in the group you think is more affected by the outcome, okay? So this is an example where maybe you're doing a study and you just suspect that, that women are more likely to be arrested for drunken disorderly than men. And so you get a bunch of police records and you identify the gender of the person in the record and you search through the record for drunken disorderly. Well, if you have that bias in your head, maybe you search a little more carefully among the women, okay? And you find a little bit more. So that is a form of information bias. You're mismeasuring, in this case, the outcome, drunken disorderly, in one group compared to the other. The solution there is blinding. You have to not know whether it's a woman or a man's chart when you're looking for the outcome in that case. Social desirability bias. Worry about this anytime someone is asking a survey question. Respondents answer a questionnaire so as to impress the interviewer. So if I walk up to someone on the street and I say, you know, how many hours of television do you watch a night? They might say, oh, none, or just 15 minutes, when in fact they're binging 8 hours of Netflix. It depends on the person, how honest they're going to be, but this can certainly happen. So anytime there's a questionnaire where there's some kind of social desirability component, there's questions that are a little sensitive, drug use, sexual history, etc., be a little bit worried about this form of mismeasurement, this form of bias. The solution there is offering anonymity, giving surveys in a private way. You can give them a tablet, make sure they can answer it away from prying eyes, and things like that. So that's sort of a whirlwind tour through information bias. It basically boils down to mismeasurement. You just always want to ask, was the exposure or outcome measured appropriately? Differential mismeasurement in different groups is particularly bad, but careful study design can mitigate a lot of these problems. Of course, as with all biases, you've got to design the study right from the beginning because there's no fixing it after the study's done.